Anticoagulation is a pretty big topic, and it has a lot of applications, not just within cardiology, but we'll talk about it with vascular care and stroke and things like that too, especially with antiplatelet therapy. But certainly this is the lion's share of where we're going to see patients coming across. So switching gears a little bit, we talked about arrhythmias during the off week last week. If you saw that lecture, talked about AFib quite a bit. So that's a big indication for anticoagulation. One of the most common chronic conditions that's going to require long-term anticoagulation is patients with atrial fibrillation. So if we connect those two topics and start going down that pathway, the other thing to think about too with conjunction to the other lectures is acute coronary syndrome. We're going to talk about antiplatelet agents as well in a little bit more detail today. So hopefully that'll answer some of the questions and some of the things I kind of glossed over a little bit during that lecture. So anyway, hemostasis, formation of thrombi, aka blood clots. So the blood is stopping or pooling somewhere. Oops, I just took out my monitor. Anyway, the blood is stopping or pooling somewhere, and it's usually trauma or injury induced, but clots can happen over time depending on what's going on. It doesn't necessarily have to be trauma or injury induced. So if you have someplace where the blood is just sitting due to a fibrillating atria or blood flow that's not good to an extremity or something like that, you can be at risk for a clot too. So I like the term red clot versus white clot. I know it's very rudimentary, but I think it helps me remember it, so I'll share it with you guys. So you guys have probably heard this at some point before, but I think of red clots as red blood cell and fibrin rich. So these are due to blood pooling, and these would be more associated with a venous thrombus or a thrombus forming in the atria of the heart. So think about blood just sitting, it's not moving with the velocity like it normally would. A white clot would be a platelet-rich clot, and that's more of like an arterial thrombosis. So the reason why I like splitting it up like this is I think it's easier to remember how we treat each of the different ones. So, for example, drugs that are caused, or people who are at high risk for venous thrombosis or atrial fibrillation-related clots, we usually don't use antiplatelet agents. We use an anticoagulant that actually works on the clotting cascade and prevents these fibrin-rich clots from forming altogether. In fast-moving blood, like blood moving through coronary arteries, it's usually not pooling. It's because that wall gets occluded, breaks open, there's inflammation, the platelets aggregate, and then you get a clot there. So that's just a natural process that the body's going to have happen, and we can stop that by giving antiplatelet agents. Similar for some other things too, which we'll talk about during stroke care next spring when we talk about neurology. But that's the basics of it, and I think that's helped. So remember, red clots, red blood cells, fibrin, clotting factors, and white clots, platelets, and that's how we differentiate antithrombotics versus anticoagulants. And of course, you can have both coming together. So like here's an example. So you have a plaque rupture through an artery, you have platelets aggregate, they're going to be an immediate response to some sort of a tissue trauma like that. And then ultimately that's going to recruit red blood cells too. So you do get components of both. Excuse me. You do get components of both in different clots too, but for a fast-moving blood flow area like a artery, the platelet's going to be the majority problem factor because that's going to happen first. Okay, so let's start with talking about platelets a little bit and talking about antiplatelet agents. So platelets if you get compromised integrity of vascular lining, platelets will come based on exposure to collagen fibrils. So the collagen fibrils, they kind of like a signaling. They say, hey, platelets, come in, hang out with us. Platelets come in, they adhere to the surface, and then the platelets pull their friends in too, and so it becomes a big platelet party. What we can do is reduce the signaling pathways that platelets use to communicate with each other, and we can do that by a couple of different mechanisms. So there's some listed here. So adenosine diphosphate and thromboxane are secreted by platelets, and those activate other platelets. So you might remember back to, we talked about the arachidonic acid pathway. What was one of the mediators that cyclooxygenase produces? Thromboxane, right? So that's where aspirin's mechanism of action comes into play. Platelets link up via circulating fibrinogen as well. I very briefly mentioned GP2A3B receptors, which I also said you don't need to know, and you don't. I'm just saying that again because it's a different mechanism, and I'll show you kind of how it all goes together here in a second. But platelets have about a 5-day life cycle. It's always important to remember if you work in surgical services or if I'm trying to think of another example where this would be relevant. I'm failing off the top of my head, but someplace where you need to stop somebody's aspirin or antiplatelet agent and let their body get back to normal. Usually you're looking at about 7 days, and that's just to be on the safe side to let your body fully clear all those platelets that have been monkeyed with by the drug. The drug doesn't last that long. It lasts like a day. So the drug's gone. It's just getting the platelets back up to speed so your body's produced and they've kind of fully cycled over. Yes?
Is that like the idea of behind like bridging, like getting someone ready for surgery?
Yes. Bridging's a little different. So you wouldn't, right, so you wouldn't bridge somebody on an antiplatelet agent. You just stop the antiplatelet agent. The risk of throwing a clot if you stop somebody's antiplatelet is really low because usually they're on it for secondary prophylaxis or something like that. An anticoagulant, it depends on the risk. And so that's a good question. We'll come back to that later in the lecture. Okay, just I'm showing a picture of platelets and how they talk to each other. So again, fibrinogen linkages, GP2B3A receptors here. So again, that's that fast-acting IV drug that I don't care about you knowing. And then we'll talk about some of the other actions here in a second. So our medicinal agents, the primary two we're going to talk about a little bit more detail today, aspirin and the P2Y12, aka ADP inhibitors. So they prevent interaction of ADP with G protein coupled ADP receptors. And aspirin essentially inhibits thromboxane production via upstream stopping of the cyclooxygenase pathway, like we talked about during inflammation and some of those processes. I'm not going to talk about dipyridamole today. That's a stroke-only medication. It's got some odd utility. It's a very odd, uncommon drug, so don't worry about that for now. And there are some other things. I just thought I'd throw this in there. There have been looked at. It seems like antiplatelet agents we haven't seen. We have two drugs really that work, right? We have aspirin and we have the P2Y12s. So that's it. There's 3 P2Y12s, so there's technically 4 drugs, but there's really just two classes. So why isn't anyone capitalized on this? Because so many people take these drugs, it'd be a huge market. So there are some people trying to look at different things. Like there's a thrombin receptor antagonist to look at that, and it's called Vorapaxar, but it was found not to be beneficial and increased bleeding with PCI. So it was given in a phase prior to catheterization, thinking it might be a replacement for a P2Y12 load, and it didn't help. So anyway, we might see some interesting areas of research in the future just because it seems like there would be a lot of targets. If you look at a platelet here and all the different things that can activate a platelet, it's pretty complex. And so the drugs you have manipulate some of it, but not all of it. So here we have ATP and ADP with your P2Y12 inhibitors, and then you have thromboxane activating these sides. But there's a lot of other things going on too. So anyway, just to throw that out there. All right, talk about aspirin in a little more detail. Aspirin is also known as acetylsalicylic acid. It's abbreviated ASA quite commonly, so if you ever see that, that's what that is. Again, inhibits platelet activation by suppression of thromboxane 2. Most often we give aspirin as a low dose, or aka baby aspirin. I don't want you to memorize aspirin doses, but it's good to know. And you'll see people take aspirin doses all over the place. And a lot of people take aspirin just because they think it's good to do. And it's always a good intervention to say, okay, why are you taking this full-strength aspirin once a day? Oh, I saw a commercial for Bayer and it said to take it. And you're like, well, it's probably not actually what it said. Maybe you thought that in your head when you were watching it. But let them down gently, of course. And it's always good to make sure they actually have an indication, because there's no point in taking an antiplatelet agent when you don't need it, because you're just going to risk bleeding out if you get in a major accident or have to get rushed to surgery for some reason. It's not a good complication to have happen to you. So it's always good to look at somebody when you're looking at somebody working up their profile before you meet them for the first time, or a new patient. If you see aspirin, make sure they have an indication for it. It's an easy one to check off. Low doses produce good platelet inhibition, so really you don't need the 325. 325 is more studied in like post-CABG patients. There's some decent evidence with the higher dose there. But generally speaking, the 81 milligram is going to be sufficient for pretty much all people. We'll talk about a little bit of a difference there with some stroke patients might require the higher dose versus the lower dose, and some of the evidence there. Again, that's next spring, so don't worry about that now. Yeah.
What is CABG?
That's coronary arterial bypass graft. So that's a bypass. Okay. Instead of putting a stent in, actually you're putting a graft artery in to bypass the blockage. So sometimes an artery might be so blocked or have such a long blockage that a stent just isn't going to suffice. That's not always the case, and it's preferred to put a stent in, but occasionally you'll need to actually bypass the entire artery. So when you hear like quadruple bypass, triple bypass, that's what they're talking about as a CABG. What else? So 325 loading dose is where we'll see that dose done. Is if somebody comes in an acute MI or an NSTEMI, we'll start the loading dose with that particular strength. But honestly, chronically, they're going to be on the 81 milligrams. If you're wondering why the doses are weird, why 81, why not 100 milligrams? 81 is a grain, and it harkens back to old ways that we used to measure medicine in grains instead of grams, which convert weirdly to grams. So anyway, 81 milligrams is what we've got. And just so we're clear, you don't give aspirin to babies. It's a terrible name because saying it a baby aspirin, but everybody calls it that anyway. But aspirin is contraindicated in children, actually, which we'll talk about during peds. So I don't want to get too off track right now. Don't be like, oh, that's the baby dose. Well, yes, it is the baby dose, but not for the babies. Available as a suppository as well. So if you have somebody coming in with an acute coronary syndrome, NPO, or unconscious, can't protect their airway, you can give it rectally, and it does absorb quite quickly. And again, lots of inappropriate use, so check your aspirin use on your patients. Okay, so primary prevention, over 50, 10-year risk factor greater than 10%. This is a kind of a question mark. There's some guideline recommendations over whether you should prescribe aspirin to anyone who's over 50 and has a 10-year risk factor or a 10-year risk score of greater than 10%. You might consider giving them an aspirin just because you might consider that they're generally high risk for a heart attack. Now, is that actually going to do anything? I don't think there's good evidence to say that reduces mortality all that much, but it is a possibility. Pre and post acute coronary syndrome, certainly aspirin is going to be required. Patients requiring anticoagulation who are low risk, so we talk about the CHADS-VASC or CHADS-2 score. So those patients that score 0 or 1 potentially could be on just aspirin. For atrial fibrillation, and status post-stroke or TIA. So these are the major areas of use. There used to be all these other indications for aspirin, like diabetic patients. It was recommended to take a baby aspirin. That's not thought as safe anymore. It's just unnecessary. There's no evidence to say that helps people in the long run. Granted, the risk of bleeding, so going into side effects, the risk of bleeding is really low with aspirin. You could take a baby aspirin a day and probably be just fine. And even some people... we started this, just to give you background, we started this new initiative where we sit in our pre-op area. We get into the hospital really early before people start surgery, and we talk to people before they come in and make sure their medications are up to date in the computer system before they go into surgery. It's actually been a huge benefit because surgical, no offense to anyone who's worked with the surgical group, but they are awful at updating med lists. Their H&Ps are 100% of the time wrong. And I'm not even exaggerating. They're really bad. It's like, you have no idea what this patient's taking. But they only care about a couple drugs, anticoagulants and antiplatelets being one of those. And sometimes if a person, like if they have a really high stroke risk or they've had strokes in the past, they'll just keep them on their baby aspirin. Or depending on their acute coronary syndrome history, they might keep them on their baby aspirin. So you can go into surgery still on aspirin. I've seen it done plenty of times, and I'm not too surprised at it anymore. It's rarer. You usually stop it if you can. But the bleeding risk is relatively low compared to, like, if you sent somebody in fully anticoagulated on warfarin, that's another story. So other side effects, dyspepsia, usually not seen with low-dose aspirin. Another reason why 81 milligram aspirin is preferred, it's got virtually no side effects associated with it, and it has a potent enough antiplatelet activity to be effective. If you up it to 325, you start to get this dyspepsia where people just get like kind of like a heartburn type reaction to it. And then aspirin used to be used for pain. Well, it still could be technically, but you have to take pretty high doses of aspirin, like grams per day, not 325 milligrams. That's a full strength. But if you're taking 1 to 2 grams a day, that could definitely cause some GI upset. GI ulcerations can happen due to any NSAID consumption, like ibuprofen can cause this, naproxen can cause this. It's a risk that comes with inhibiting that arachidonic acid cyclooxygenase pathway. Remember, those housekeeping prostaglandins are beneficial for the GI epithelial cells, and if we get rid of them, you can put yourself at risk for an ulceration. So again, a lot of this stuff is not relevant for a baby aspirin. It's just you don't get enough of it to matter. So don't think that these are this terrible medication. And again, if somebody is taking this for no reason, it's not the end of the world, but still, they're still taking an antiplatelet agent for no reason. Contraindicated in kids less than 16 years old, there's something called Reye syndrome, which is an encephalopathy that occurs associated with viral illness. Extremely rare, very odd. No one really knows exactly what causes it, but it's heavily linked to aspirin use in conjunction with viral illness. So aspirin use is contraindicated in kids less than 16 years. And then I talked about this dipyramidal combination, stroke prevention only, so you don't need to worry about that for this exam. All right, let's talk about the P2Y12s. The first drug talk about is Plavix, or Clopidogrel is the generic name. Clopidogrel is the first drug of its kind on the market. It's the oldest one, it's best studied, and it has probably the most broad use of applications just because it's cost effective. It's generic now, so compared to the other two, which are still pretty expensive. 300 to 600 milligrams load. So if you go back to your ACS lecture and you want to like put some of this together, this is where those loading doses come into play. So if somebody comes in, and before at Abbott we had ticagrelor, which is the drug we use now during an acute coronary syndrome, we used to load people with Plavix. So they'd come in and you give them 600 milligrams or whatever it is, and it's 300 if they're an NSTEMI or however that breaks down. And then you wait, or you hope that it works quickly. Now you have all these issues. So one thing, it's a prodrug. So it requires CYP2C19 and 3A4 to convert it. It means if you have those enzymes manipulated by other drugs, or if you have some sort of genetic polymorphism where you aren't a fast metabolizer or you're an ultra metabolizer of some kind, you're going to mess up the way Plavix gets into your body, and it might not be as effective. And you can't do genetic testing while somebody's having a heart attack and you need to get them to the cath lab in the next 5 minutes, right? It's not feasible for obvious reasons. If they have an NSTEMI and it's low risk or something, maybe, but even then it's questionable. So up to 30% of the patients are thought to have some sort of polymorphism that makes Plavix less effective or ineffective. Now, where that actually falls on that spectrum, it's a big difference, because turns out you can actually mess up Plavix's prodrug conversion substantially without necessarily decreasing its clinical benefits. But how significant that is questionable. So there's this big thing that came out when I was in school, so probably 8-9 years ago. And everyone takes a PPI, basically. I mean, I'm generalizing here, but a lot of people take PPI. So Prilosec, Protonix, Nexium, they're common medications for heartburn suppression, right? They're over the counter, except for Protonix. But anyway, Prilosec is generic omeprazole, and omeprazole was the first one of these to go generic. So anyone on a PPI was almost exclusively on omeprazole for about a decade, or 5 years at least, before some of these other drugs went generic, because that's what insurance is paid for. So you had all these people on omeprazole, and then Plavix was a popular drug for these reasons we're talking about today. And it came out that Prilosec interferes with Plavix's conversion into its active form. So it interferes with that prodrug to real drug conversion. And everyone got taken off of omeprazole. So there's a big study that came out and said there's this huge risk here. You're decreasing Plavix's efficacy. We need to stop this. So everyone got switched to H2 blockers. Like ranitidine's prescription skyrocketed for people on Plavix. Omeprazole tanked. Then another study came out like 2 or 3 years later that said, just kidding, we actually don't think there's any actual clinical impact. Now that study was maybe not the best designed, in my opinion, but at the end of the day, we do prescribe them together now, and no one really cares about this anymore. So long story short, there's a big knee-jerk reaction to this study. People changed all these acid-suppressing regimens for these patients with heartburn because of their Plavix interaction. Turns out it probably doesn't happen that much. Now, if you want to be on the safe side, we'll talk about pantoprazole or Protonix when we talk about GI, and I will bring this up again because I think it's a good story. But Protonix interferes with, I think it's 2C, it's a different enzyme, I believe, it messes with, so it doesn't have as big of an impact on Plavix-specific metabolism. So if you are going to give somebody a PPI, strongly recommend you choose Protonix, which is pantoprazole, over any of the other ones, just to be safe. You might as well. They all work the same. There's no difference between any of them, so might as well go with the one that's least likely to interfere with their other meds. Plavix, out of the 3 P2Y12, is the lowest platelet percentage inhibition. So it's actually the least potent if you want to look at platelet percentage inhibition as terms of potency. Also has the lowest bleeding risk, which makes sense because it's the least potent, which makes it advantageous. It's highly beneficial. It's got good outcomes. It works for its purpose, and it doesn't cause a lot of bleeding. So that's all good. We don't need to really destroy somebody's platelets and their ability to clot. That we don't want to overdo it or they're going to bleed out. So if we can get that balance where we're reducing that time that the body takes to form those initial clot phases, get that person to the hospital, give them some extra window of time to get to a cath lab if they have a second event, that's ideal. And then, of course, it's generic, so it's relatively inexpensive now. Prasugrel was the second one on the market. It's got a similar dosing strategy, so a loading dose plus a maintenance dose. Both Prasugrel and Clopidogrel are also once daily meds, so they're pretty convenient. Prasugrel is also a prodrug. It's less prone to drug interactions just because it has a lot of different CYP pathways that can metabolize it into its active form. So the odds of you shutting all those down and preventing it completely is virtually impossible. So it's just not shown to be a huge deal for those genetic issues or those drug interactions as much as Plavix was. It's the longest lasting drug, a lot of active metabolites, and it's also got the highest bleeding risk for those reasons. It is contraindicated if you have a history of stroke or transischemic attack. We also use these drugs post-stroke commonly, so that's why I'm bringing that up. So if you have a history of some kind of a CVA or a stroke, then you would be in the position not to take this medication. So it does have some restrictions. It's probably not the most popular use just because of its higher bleeding risk than clopidogrel. And then finally we have ticagrelor. Ticagrelor is a similar dosing strategy. Again, there's a load and a maintenance dose. The maintenance dose is BID. Ticagrelor is shorter acting. It's not a prodrug, and it is reversible binding. So it's a little bit different kinetics. The other one's irreversibly bind. It may require less holding time to get rid of the body to rid the body of the effects. So it means that you don't necessarily have to hold it for a whole week prior to surgery, but that's still debatable whether or not the platelets need that time to turn over. But because it's reversible, it's thought if you stop giving it, it'll just dissociate with the receptors it's interacting with, and then simply the platelet will recover that way. Some 3A4 metabolism, but fairly robust when it comes to drug interactions. Highest percentage of platelet inhibition. It's actually contraindicated to use it with a full-strength aspirin for any indication because of that risk. So it is a bit more potent, and if you combine the two, you could risk extra bleeding with those patients. For some reason, it causes dyspnea with people. Don't know why, but it does have a caution for asthma and people with chronic bradycardia for some reason. Again, I don't understand that fully. The reason why we like this drug, or why I like this drug, and why Abbott likes this drug is because it shows superiority to clopidogrel for prevention of major adverse cardiac events in the acute phase of an STEMI and STEMI unstable angina episodes. So this is our preferred drug. Works fast, high percentage of platelet inhibition, very little issues with enzymatic issues. So you're going to absorb it, it's going to work, you don't have to worry about it getting metabolized with the right product. As far as maintenance goes, that's where it fails, I think, a little bit. Twice day dosed, a little bit more expensive. So a lot of times you'll see people loaded on ticagrelor during the acute phase and sent home on Plavix, assuming their genetic profile lines up. They do actually do some genetic testing now. Plavix is probably one of the biggest examples of pharmacogenomics being used in practice. So they can see how rapid of a metabolizer you are for certain pathways, and if Plavix is going to be a good option for you or a weaker option for you. That's probably one of the most robust areas of pharmacogenomics currently, where they can actually look at your profile to see genetically how likely you are to make that drug work. If not, then you're looking at one of the other two, Prasugrel or ticagrelor. This just shows, I think this is the same slide I had in the other lecture, but it shows, comparatively speaking, the differences in the drugs. So loading doses, metabolism, half-life. What else is on here that I care about? You can see there's hold times here, 5-7 days again. That's pretty common. Yeah, if you want to look up the studies, those are the studies that were done on them if you care to do that. But other than that, it's yeah, that's pretty much all we've talked about. So I don't want you to know too much of the specifics as far as the differences in hours and half-lives and things like that. But the big things are, I would say clopidogrel is generic, it's affordable, it's commonly used. They're all indicated for the same things though, so they are all interchangeable. But Prasugrel has that higher bleeding risk and that stroke contraindication, and ticagrelor has some evidence showing that it's better in the acute phase. And those are the big take-home points for this module and antiplatelets. Do you guys have any questions about antiplatelets before we move on to anticoagulants? Yeah.
So this is like targeting the blood clot.
Correct. Yep. So this won't do anything to, well, if you have a clot that's advanced and combined, it will still break down the platelet component, so it might loosen the clot so it can move, but that could cause a further blockage somewhere else. You aren't going to break down that red component of the clot. That's why during the acute phase we give an anticoagulant too. You give an IV bolus of heparin at the same time, so you're hitting it from both angles.
Sorry.
Yes?
When did you say you used Prasugrel?
It would be an alternative for somebody who maybe has a polymorphism and doesn't, or has failed Plavix. Sometimes they don't always do. I think genetic testing is standard now for that, and you can figure that out beforehand. But I think when Plavix first came out, and we had these alternatives, people would fail it. They'd come back in with a heart attack, and they're like, I've been compliant with it. They say, well, let's not risk it. Let's switch somebody to a different agent. Yep. All right, the clotting cascade. Oh, everybody's favorite thing. So clotting cascade is not that bad. All you have to know really is that there's a common pathway, and that's what we manipulate for drug targets. So factor 10 and factor 2, aka thrombin, are the two major targets for drug pathways. So any drug that is going to be worth anything when it comes to anticoagulant has to do something with those pathways. Now, it might inhibit other areas too, and that's fine, but it has to interact there. So some of the new drugs we've seen coming on the market, you might have seen ads for things like Xarelto and Eliquis. They're really popular meds right now. They're factor 10A inhibitors, so they inhibit factor 10A directly. Warfarin works on a bunch of different factors. Heparin works on a bunch of different factors. So we're going to talk about that and break that down a little bit. But the point is, it doesn't really matter. As long as you get factor 10 and factor 2, or one or the other, that's all you need, because that's that common pathway, and that's going to prevent the majority of your anticoagulation efforts from ever occurring. Or you get what I'm saying. I said that wrong, but you guys understand. Okay, so red clot targeting here, and medications generally target that common pathway. Like I said, there's a lot of different products out there. We have oral, we have IV, we have sub-Q, and they have a lot of different utility depending on what you're trying to accomplish. The goal is to prevent synthesis and activity of the most active clotting factors, and patients have a lot of indications. We talked about some of these already, but again, AFib and venous thromboembolism are going to be the two biggest things you're going to see for chronic anticoagulation. In the acute phase, things like acute coronary syndrome. Some people might be anticoagulated status post like surgeries, orthosurgery, general prophylaxis as well, just depending on the risk. So some people, like OB patients, for example, postpartum might be at risk if they meet certain criteria, so they might be on a low-dose anticoagulant, even though they don't meet any of these criteria per se, but just because. We might anticoagulate somebody who's bedbound in a hospital ICU. Again, very low dose compared to maybe a therapeutic dose, but still prophylactically we do some stuff like that here and there, even though they don't have the goal is to prevent a venous thromboembolism from occurring in the first place. So it's those patients at high risk for VTE. Frequent monitoring. So pharmacists have kind of made a name for ourselves in hospital care. We do a lot of anticoagulation monitoring. It's kind of a bread and butter skill any hospital pharmacist has. And so we do a lot of level monitoring. Anticoagulants are really high-risk medications. Tons of people take them. Doesn't mean they're safe. One of the biggest presentations to the hospital for medication reasons are two classes of drug. One is anticoagulants, and the other is hypoglycemic agents. Those make up the lion's share of medication-related emergency or hospitalization, emergency department visits or hospitalizations. So monitoring is important for a lot of these agents. Now, some of the new ones don't require monitoring, so we'll get to that and talk about the pros and cons of that here in a few slides. Okay, let's start with heparin. Heparin's kind of like the OG anticoagulant, if you will. It's got a lot of versatile uses. It's super cheap. It's an essential med for any type of hospital care, and it's widely used today, and it probably will still be widely used 50 years from now, I would imagine. No, I could be wrong, but I don't think it's going anywhere. We understand heparin, and heparin works quite well. So heparin potentiates antithrombin, which complexes to factor 10A to prevent the formation of thrombin. It also inactivates factors 9 and 10 and prevents the formation of thrombin that way. So there's a couple, or fibrin, excuse me. So a couple different mechanisms, but again, we're focusing on that common pathway, and it certainly checks those boxes. Standard therapy for a lot of different conditions. You can give it sub-Q or IV. Usually for sub-Q, it's prophylaxis dosing only. So again, those patients who are immobile in the hospital, a lot of times we use sub-Q heparin twice or 3 times a day. It's a fixed dose. We just do 5,000 units every time. And compared to like if somebody had a DVT and we were going to treat them with heparin, it'd be like 20,000 units twice a day, so you're injecting a lot more volume. Sub-Q for treatment that way just doesn't make a whole lot of sense because the volume you have to inject subcutaneously and the dosing is kind of weird and the weight base gets a little confusing, and there's better options now. So really this is an IV product with the exception of sub-Q prophylaxis. That's what you're going to see used clinically. IV, we can use it for everything. So again, we give an IV bolus of this when somebody comes in with an acute coronary syndrome, so that's relevant to this module. Talking about venous thromboembolism, if somebody came in with a pulmonary embolism, you could give start them on a heparin drip, depending on how severe it is. That'd be a common strategy as well. You can heparinize somebody if they have unstable atrial fibrillation, like I talked about in the last lecture. So there's a number of ways you can do it, but Most commonly, you see it done just for people who have to be bridged to something else while they're in the hospital, or people post-surgery who want to get started on something while they're waiting for their other anticoagulant to get back up to par. And usually that's warfarin. So when I talk about warfarin, this will make a little bit more sense, the bridging concept. I'll come back to that. But heparin works really quickly. Essentially, once you've injected it, you've got about immediate effects or so, maybe 30 minutes at most. So it anticoagulates you quite quickly, whereas an oral drug still has to get through the GI. A sub-Q drug still has to penetrate that subcutaneous tissue and has a longer peak associated with it. So that's where heparin has the huge advantage, is its quick onset and quick offset. You turn it off, half-life's 1 to 2 hours. Yes, you can overdo it and cause bleeding on heparin, but the good thing is that it wears off of your system quite quickly compared to anything else anticoagulant. We also don't have to adjust for renal dysfunction. So for our renally impaired patients, heparin's a preferred agent for anything acute as far as hospital care goes. You might hear heparin referred to as UFH or unfractionated heparin too. That's the same thing. That's regular heparin. The difference is there's low molecular weight heparin, which are different products, which we'll talk about, but unfractionated heparin or regular heparin, it's the same thing. I like to talk about this because it's kind of a unique thing in the pharmaceutical world. It's one of the few drugs that's still produced in a natural way, if you want to talk about it like that. So they actually use this, they actually extract heparin from the intestinal lining of pigs, and they process it and fractionate it that way and get some sort of a heterogeneous product. They tried to make heparin synthetically, and it's a lot more expensive. It's difficult to do. It's a complex chemical reaction. It just isn't as efficient. And then there's other ways they could do it too, but again, still not as attainable as the porcine product. So if you hear heparin porcine or see that it's a porcine product, that is correct. It is actually from pigs. So occasionally get people for certain religious reasons who don't want any porcine products whatsoever, and we can't use heparin. Or we'll talk to them and say, look, this is the absolute best thing. We have to do this. But some patients will be, it does come up occasionally that they will refuse a porcine product, or they know that heparin is porcine based. Now, once it goes through all these processing and such, is it still really pig? I mean, yes, I suppose it's part of the pig, but you've cleaned it up with a bunch of chemicals, so I don't know how recognizable it is as porcine, but it's still, yes, technically it is a pig product. Okay, heparin is usually given as an IV continuous infusion, so we give it over a certain rate per hour, so you're just infusing it continuously. Usually there's a dosing strategy that mimics this. Most hospitals have protocols for this. So for example, if you're admitted at an Alina hospital, you'll order your heparin therapeutic protocol, and you say, oh, this patient has atrial fibrillation, they're warfarin subtherapeutic, I want them on heparin, let's get it going. And then that kicks the order over to a pharmacist who says, yep, looks good. And that kicks it over to the nurse. The nurse says, okay, I'm going to click my buttons on my computer that tell me what to do. So it puts in the weight, it calculates out what they need to be, it tells them exactly what to start infusing it as, tells them exactly what to give their bolus dose, and it tells them exactly when they need to check the first heparin level. It's all automated, it's all protocol driven based on calculations like this. So I don't want you to know any of this, and you're never going to have to do this in your career unless maybe you go to like a developing country that doesn't do protocols like that. You might have to do some math, but generally speaking, all this is done for you. So usually you're looking at a loading dose over 10 minutes, plus a maintenance dose at about 120 units per kilo per hour, so again, weight-based. And then you target an APTT level, which is about assuming how anticoagulated, which is antiprothrombin time, is what that stands for. So that's looking at your factor 2, the ability of your drug to inhibit factor 2, if you think about it that way. And this also reflects an anti-factor 10A level. So there's also 10A levels. Some places you go, this is probably going to be the biggest difference in protocol per institution or health system. Some places might do APTT, some places might look at 10A levels. It's all extrapolation. It's basically the same thing. As long as the protocol is based off one level, that's all you really need to know. We used to do heparin levels, which doesn't really exist. It'd be like a calculation off of this, and it would give you a different number, and we stopped doing that a couple of years ago. Anyway, if things aren't looking good, either your APTT is way up or too low, then you adjust it by about 10% up or down and recheck or rebolus if you need it, or stop the drip altogether and wait. Or if it's really bad, it says consult pharmacy, and you're like, you get a call from the nurse. I'm like, I don't know what to do. That's not a good joke, but seriously, sometimes it is complicated. Patients don't always, react to the drugs the same way. Usually, it's pretty doable. And again, the worst case scenario, you can stop the heparin drip, and it's going to get out of their system fairly quickly. Heparin-induced thrombocytopenia is a major side effect and rare complication, but a serious complication with heparin. It's kind of an interesting reaction to the drug, so I'll spend a minute or two on it. It's a precipitous, like greater than 50% drop in platelets 5 to 19 days into therapy. When this happens, you need to stop heparin immediately. You don't re-challenge for at least 100 days, and it actually increases your chance of clotting. So what HIT is your body actually makes an antibody complex with the heparin molecule, and that causes platelets to activate in rapid form. So even though your platelets are dropping, it's because a whole bunch of them just activated suddenly, kind of like a super heparin of sorts. Well, or like, yeah, that's kind of how I think about it. Anyway, so what happens is the platelets all break apart because of this immune system reaction that's going on. And then you get complications. First of all, clotting risk is huge. So you could have a stroke, you could have any type of venous thromboembolic event, pulmonary embolism, etc., MI. And then what can happen is you get occlusion in microvasculature. So this is a picture of this. Kind of gross, but this can happen with HIT, is where you get an area of the body that gets very occluded, it's necrotic, it's just basically bleeding out the whole time. So not a pretty situation, and it's something that we do have to just do monitoring on. So you want to watch the platelet levels really carefully in these patients. Where it gets really confusing, I think, is if they're post-surgery and they've had blood loss during surgery and they lost a lot of blood and their platelets dropped, and you're like, well, was it heparin or was it the surgery? Man, I don't know. That gets a little tricky, but always be on the lookout for HIT. Okay, low molecular weight heparins. So these products are also a porcine, technically. So what they do to make these is they take actual unfractionated heparin and they do a bunch of reactions to it and they make this. So technically, yes, the base product is, it's like if you took a pork chop and cut it up into little pieces and dunked it in acid and then got acid pork chops that are mini. Something like that, right? But similar action to heparin. It's a smaller molecule. The incidence of HIT is quite a bit less. However, if the patient does have a history of HIT, you probably don't want to give the product just because. Mostly targets factors 2 and 10. The nice thing about this is it's got pretty predictable kinetics, and you don't necessarily have to monitor these patients on it. Usually you don't monitor. We had, well, we still have a hospital monitoring protocol sometimes that we're supposed to use, but package insert and research in most places don't monitor levels on these patients. So you give an injection, you get a peak onset about 4 hours after the sub-Q injection, twice daily dosing, renally eliminated, so you want to adjust it for that. But it's all weight-based too. And it's really pretty straightforward. It's like 1 mg per kg usually every 12 hours is how you dose these. So compared to heparin or sub-Q heparin, if you're going to do that therapeutically, these drugs have taken over. So we're talking about bridging somebody outpatient, or like let's say somebody comes into your, an example of where this might happen, somebody comes into your ER, urgent care, clinic even, and you're checking their INR, which is what warfarin's measured by, and it comes back really low. So it means their warfarin's not been effective. You're worried about them having some kind of a clotting event, so you prescribe them this drug twice daily for 7 days or whatever, and then you have them come back and get their level checked after you've monkeyed with their warfarin dose a little bit, and hopefully you can get their warfarin back to where it needs to be, and then you stop this drug. It's the same thing post-surgery. So somebody who's really high risk, that's where that CHADS2 VASC score comes in. Usually if you're higher on the CHADS2 VASC, post-surgery, they're going to keep you on some sort of a bridging therapy, and that's what these drugs are. So you stop the warfarin 7 days before surgery, whatever it may be, wherever you're instructed to. You start taking your low molecular weight heparin. You stop it the night before surgery, so you come in that morning 12 hours later, whatever it is, and you have virtually no anticoagulation on board. But it's the smallest window of time possible. That's the goal. We don't want you to go without anticoagulation for a whole week if you really need it. We want to make sure that things are all taken care of on that end. So that's where bridging comes into play, and it'll make a little more sense when we talk about warfarin's kinetics, but that's mostly what these drugs are used for. Their place this drug is really useful is as a prophylactic agent. So it's a once daily prophylactic agent instead of twice daily, and so you see this done a lot, even in the hospital, even though it's a little bit more expensive than like prophylactic heparin. Sometimes it's just easier to do something once daily than 3 times daily, depending on what the patient needs are. And so we see that done quite a bit, where it's just a slow dose once daily, and that's all you need to do. But these drugs are more expensive than like a sub-Q heparin. They come in these pre-filled syringes, and even though they're generic, Lovenox is the brand name of enoxaparin. It's been around for a while, but it's always going to be kind of expensive, even though it's a generic product, just because it's of the processing behind how they get the drug and also the packaging. It comes in these preloaded syringes that just more expensive to make that than like a little vial of heparin. All right, I talk about bridging therapy. You can substitute this for heparin in most cases. Biggest cons here, not fast acting. That's where heparin has a big advantage. Not easily titratable. If you overdo this, you're stuck with it for 12 hours or so. You don't usually monitor it, which is a benefit for the patients, but also if you have an unstable patient, you don't really know what's going on. Sometimes monitoring is a nice safety net. You can see how the drug's affecting the person with a lab value. In this case, you don't. Not always convenient. Patients don't like injecting themselves, in my experience, but usually it's short term. Most people don't do this for years and years. Usually it's a week or two, and it's expensive, so there's that. You can reverse heparin or low molecular weight heparin using a product called protamine. Protamine combines with heparin to form a neutral salt. Takes about 5 minutes to work. 1 milligram of protamine approximately neutralizes 100 of heparin. I don't care you know that. It's just there for your information. Careful with this. Heparin can rebound possibly 8 to 18 hours after a dose of protamine. Can also cause sudden hemodynamic changes, specifically drops in blood pressure, and bradycardia, and even anaphylaxis-like reactions related to infusions. It's not the nicest medication in the world, but it's nice to know that if you do get somebody way overdone on heparin or you need to reverse heparin quickly, protamine is available to you, especially if you think about like a surgery and the person's on heparin for some reason, you need to reverse it emergently. That's a good option to have. All right, let's take a 5-minute break and we'll come back and start talking about the oral anticoagulants. Okay, anticoagulation always takes me longer than I think because I talk a lot. So here we go. Let's try and move a little quicker maybe. Okay, vitamin K antagonist, aka warfarin. So here warfarin referred to as a VKA or vitamin K antagonist. It's the only vitamin K antagonist on the market, so it's synonymous with that class of drug. There are some super warfarins out there that are used as rat killers, rodent poison. So if you ever hear somebody like, oh, I'm on rat poison, saying it as a joke, which I feel like old guys love to use that one. That's because, anyway, it is actually true. Not all poisons are like that, but there are some that are anticoagulants. So anyway, brand names Coumadin or Jantivin. Warfarin's kind of an odd drug where if somebody is on a certain brand name of it, they will want to keep them on that brand name. So we actually stock, so there are generic versions of warfarin out there. There's plenty of them. Warfarin's been around forever. But if somebody is on brand name Coumadin, they won't want to switch off brand name Coumadin because those subtle differences in between potencies, even if you're looking at 5 milligrams of Coumadin versus 5 of Jantivin, could be enough that fluctuates somebody's INR. So every once in a while we get a patient, they're like, I'm on Jantivin. Jantivin's an Upshur Smith branded product of warfarin. Or I'm on the, I don't know, Mylan brand of warfarin, whatever generic company it might be. We might have to get special things in. But we only stock brand warfarin at the hospital just for that reason. Anyway, primary long-term oral anticoagulant. It's been the gold standard in anticoagulant for decades. It's a widely well-known medication. Its use is broad in terms of anticoagulation, and it's widely accepted as effective. So, other fun facts other than it uses rodent poison. Vitamin K comes from the German word for coagulation, which is coagulation with a K apparently. So there you go. So if you're ever trying to remember, how does warfarin work again? Oh, K, coagulation, clotting factors, vitamin K antagonist, warfarin. There you go. Several clotting factors, and I got a picture to describe this on the next slide, so I'm not glossing over the mechanism too much. Several clotting factors derived from vitamin K, 2, 7, 9, and then our most important one, 10. It takes 5 to 7 days for full effect. So warfarin's kind of an interesting drug. When you start somebody on warfarin, you always have to bridge them right away. One, because they probably have a clot that you want not to grow larger, right? So the first step is to make sure that they're anticoagulated to begin with. So that's helpful, and warfarin doesn't work right away. The other thing about warfarin is when you start, it actually can decrease protein C and S, which are kind of natural anticoagulants your body has floating around that are also made by vitamin K. So in that case, you want to make sure that that patient is not only anticoagulated, but not hypercoagulable. So it's fairly frowned upon to just start somebody on warfarin and send them out the door. You usually want to bridge them. And so that's where a low molecular weight heparin like enoxaparin comes into play. It is hepatically metabolized, CYP2C9 mostly, so it's highly prone to a lot of drug interactions, but there's no renal adjustment needed. That's really important when you're looking at all these anticoagulants together, especially the oral ones, warfarin is the best for people with really bad kidney function. Still is, and probably always will be unless we get better data from some of the newer agents. So for now, warfarin is the gold standard for dialysis or really end-stage CKD patients. All right, pathways and how vitamin K works. So vitamin K gets absorbed from dietary sources, right, or supplements, however you're taking it in, and then an enzyme called vitamin K reductase oxidizes it, and ultimately another enzyme called carboxylase turns it into various clotting factors and precursors. What happens is warfarin interferes with vitamin K oxide reductase, so it interferes with one of those steps. It doesn't interfere with every single attempt your body makes to convert a vitamin K molecule into a clotting factor. Some of that will get through, but the point is to dose the warfarin until you get to a point where you've inhibited enough that's anticoagulant. And that's where the concept of the INR comes into play, which is on the next slide somewhere. Yes. So we give warfarin once a day. Dosing is kind of tricky because this is not exact science. So we're inhibiting vitamin K. It depends on how much vitamin K you're eating. It depends on how active your liver is in processing that vitamin K. So there's a lot of things that are different and going to vary patient to patient. So I always say, like, for a normal-sized human being, 5 milligrams is a pretty good way to start. If your person is really large, maybe 7.5 or 10 per day. If they're pretty small, or elderly, maybe 2.5 a day. It doesn't really matter as long as you're getting some follow-up monitoring fairly quickly. You can dose adjust warfarin stepwise. The longer it takes to get to therapeutic level, the longer it's going to require them to inject themselves, which is unfortunate, but it's part of the game, and you're going to get there eventually, so just keep in mind, yeah, we got to keep it on you on the shots a little bit longer, but we'll get there. That's a big problem with warfarin. It's annoying to work with because you have to tweak it so much, and little things can throw it off really easily. So let's say your patient who never eats vegetables goes on a cruise and binges on a spinach salad every day. Well, that's going to really mess them up because they're going to have a ton of vitamin K in their body that they aren't used to. Or they take that new supplement that Oprah recommended, or whoever, and that's loaded with not vitamin K, but maybe microgreens that are compressed or something like that. So it does have vitamin K in it. Anyway, there's lots of ways people can mess this up, and it's variable depending on the person. So that's one huge negative of warfarin. I'll talk about the food interactions here in a second again, but there's not a real rhyme or reason to warfarin. Again, the general guideline: younger, healthier, heavier people are going to require more. Older, smaller people usually less. But again, you can have young people on really small doses getting therapeutic and old people on really heavy doses, or older, small, frail people on really high doses doing just fine. So that's why we monitor warfarin, because it's so variable. There's no set dose for individuals, and you have to be able to be flexible. So that's where this thing called the INR, International Normalized Ratio, comes from. Generally, targeting 2 to 3 is considered therapeutic. So the way I think about an INR is it's how long somebody's blood takes to clot in relationship to a normal person who's not anticoagulated. So if I did an INR on everyone in here, assuming nobody's on anticoagulants, you would have a INR of 1 or 0.9 or 1.1. It'd be somewhere in that tight-knit group, and that's right. That's the test working as intended. If the test is calibrated correctly, somebody without anticoagulant should be showing up as a normal INR. 2 to 3, so that basically means your blood takes 2 or 3 times longer to clot than a normal person. It's all about the time it takes to clot. That's how they measure that. Previous to the INR existing, which I don't know when it came out, it's been around for quite a while, people monitored warfarin in all different ways, and it was all messy. And then this international protocol came out on how labs sort of standardized how they checked warfarin. So everywhere you go, any clinic, INR should be the same anywhere. It's all standardized now. And there's even some take-home monitoring kits people might use here and there. From what I understand, they aren't quite as accurate as a blood test, just like any point-of-care device is never going to be as accurate. But for people who are long-term stable and have been calibrated into that system, so if we know that, well, it's showing they're 2.2, it always shows they're 2.2 to 2.5, and then every time they come into clinic, they're 2.3 to 2.6 or something. It's maybe a little bit off, but it's still enough. Then that might be a nice option for some of those people who might live in rural areas who are stable otherwise and can't get into clinic. Otherwise, usually looking at coming into clinic at a minimum of monthly for INR checks for life. So when you're in the acute phase, you're usually checking the INR like 2 to 3 days if you can. When you're in the hospital, we monitor it daily. Whether daily INR monitoring is good is debatable. Sometimes you micromanage a little bit too much with that, and then you end up with these weird fluctuations, and you're ping-ponging the patient all over the place. That's where a good pharmacist can be distinguished from we'll say a green pharmacist, right, or a pharmacy student. Most patients will require monthly INR checks, so every once in a while I get the question of, can you go longer than that? I think there are rare instances where patients might be on, if they've been stable for years and years and years, and they know what they're doing, maybe they can go longer than that, but it's going to be rare. Sometimes we change the goal target for INR a little bit, so 1.5 to 2.5 for prophylaxis patients. So this would be like post-op ortho. We don't really do warfarin a lot for post-op ortho anymore. We used to. Now they do like a twice daily aspirin dose is pretty common, but some places might still do warfarin post-op ortho surgery. But sometimes they might do a prophylactic target of a little bit lower. Or mechanical valve, they target higher too, so that's 2.5 to 3.5 for people with mechanical valve and atrial fibrillation. All right. Monitor factor 10 in patients with unreliable INR. Some patients have INRs that just don't make any sense. They're all over the place. Something that might come up, if you do a lot of work with anticoagulation, you'll hear about the term lupus anticoagulant, and that is a interaction with the way your body produces clotting factors. And I remember when I was at the VA, I spent like a month in their warfarin clinic. So yes, all I did for like a month in my training was dose warfarin, which is terrible, but that's what I did. And I spent this time, I saw this guy like 4 times, and he kept coming in, and his INR would be like 2 one week and like 6 the next week. I'm like, what the heck is going on? Was your INR 2 and 6? And he's a really normal guy. He's like, nope, I took it exactly what you told me. I haven't changed anything in my diet. He just kind of sit there with his coffee cup. I can still see him in my head, just like looking at me like dumbfounded. Like, I don't know what are you trying to like accuse me of being non-compliant because I'm not? And I'm like, no, not like that. But we're trying to figure this out. And he probably had a lupus anticoagulant or something. Why they didn't test for that, I still want to go back and figure that out. I don't know. But we can test for that. So you can run a test for lupus anticoagulant. Just because you have lupus anticoagulant does not mean you have lupus, by the way. People with lupus are much more likely to have a lupus anticoagulant, but you can have a lupus anticoagulant and not have lupus. It's kind of like from what I understand, it's like an antibody complex that happens in your body, and it can go away. So you might have a lupus anticoagulant for a year, and then you get checked for it the next time you get an event, and you don't have it anymore. So it depends, but it makes it almost impossible to rely on an INR. So we can do this thing called chromogenic factor 10, which is CFX. It monitors your factor 10 activity. It's very similar to an INR. It's measuring clotting activity, and it's a percentage. So people who are normal without anticoagulation on board are 100%. So your CFX is 100%, your factor 10 activity is 100% functional, or like 90% functional, whatever it is. If you take warfarin, it drops that down. So it's the opposite. INR, higher is more anticoagulated. CFX, lower percentage is more anticoagulated. So that's why the factor there is a little different. 20 to 40% is about a 3 to a 2, if that makes sense. Okay, don't load warfarin. Warfarin dosing is kind of more of an art form than a science, and I don't recommend just bombing somebody with warfarin right off the bat. Some of the guidelines will say start with like 10 milligrams for the first 2 days. It doesn't work. It just doesn't. I've dosed a lot of people's warfarin. I've probably dosed thousands of patients' warfarin over my career, and I've never seen a strategy like that be successful. What's going to happen is you're going to give that person, I don't have a marker, but if you give that person 2 doses of 10 milligrams, their INR is going to look normal. That warfarin's going to catch up with them. It's going to spike way up. You're going to have to pull them way back, maybe hold a dose, and then it's going to drop back down. That's what I like to call the ping pong effect, very scientific. And it's not ideal. So the better way to do it is to gradually increase them, which is why I think a middle road dose, like a 5, 7.5, something like that, is adequate. The one thing would be is if you had a patient who's been on warfarin in the past, and maybe they had a DVT 5 years ago, and they've got another one now, and they're on warfarin for 6 months after their DVT, stopped it. You look at their previous dosing history, and you're like, oh, they're really stable on 10 milligrams a day, so I'm going to start them back at that. That's reasonable, but for the average patient, you can always add more warfarin, and don't be afraid to start a little bit on the conservative side. That's my personal opinion. Some providers want it to be more aggressive, but you can't antagonize all of somebody's vitamin K at once. It's just not possible. So that's where I think there's a little bit of disagreement between some schools of thought on how to dose warfarin. Drug interactions, a lot of antibiotics interact with warfarin, specifically fluoroquinolones, macrolides, Those are the big ones. I think of anything that interferes with GI absorption also affecting warfarin, so antibiotics that are wiping out the GI flora, which is pretty much everyone has the chance to do that a little bit. That can affect your vitamin K absorption, and in that case, you can decrease your body's natural ability to make clotting factors, which is going to compound the effects of warfarin, meaning you're going to see your INR go up. So if somebody has an antibiotic on board, also if they have like an acute GI illness, that's going to increase those types of things, increase their INR, I mean. Amiodarone, talked about that the last lecture. Major common player and drug interaction partner with warfarin. You can work around it. You just got to know that it's there and keep monitoring for it. Amiodarone's tricky, though, because it takes forever to see the effects of it. You start somebody on amiodarone, and it might be 3-4 weeks before you start to see their INR creeping up. And you're like, what's going on? They've been stable. Nothing's changed. It's the amiodarone finally building up into that steady state and affecting those enzymes enough where it's interfering fully. There's a lot of supplements that affect warfarin interactions too. We'll talk about supplements in a couple weeks. Maybe not next week's an exam. Maybe 2 weeks from now. I can't remember when. But anyway, we'll talk about supplements, and I'll address that then. There's a few that are notorious for interacting with lots of different drugs. Green leafy vegetables. This is a big issue I have with warfarin education. I've heard so many people tell people you can't eat things with high vitamin K. Don't eat green leafy vegetables if you're taking warfarin. That's a terrible advice. You should eat green leafy vegetables because they're good for you. What you should do is eat them consistently. We can work around anything you do consistently in your life. That's my motto with warfarin. Just have to do it consistently. So again, that spinach salad bender that you went on your cruise, like you'd go on a spinach salad bender on a cruise, right? But let's say you did. That's a problem. If you eat, a salad for dinner every single night, and it's something you pick out of your garden, it's always the same general group of vegetables, no problem. We'll figure it out. Again, consistency is key with that. Don't discourage somebody from eating healthy because it's convenient for your monitoring. That's absurd. So I really hate it when I hear that. That's anyway. Smoking. People who smoke actually increases some of your hepatic metabolism, and so that can change the way warfarin gets metabolized and actually decrease your INRs. People who smoke might need higher doses than the general population. Alcohol obviously affects the liver. Chronic use may increase warfarin requirements and increase warfarin metabolism. And because the thing about chronic use is over time you get your liver is ramping up enzymes to try and help itself metabolize alcohol. So other things get metabolized as well. Now eventually you get to the point where you get cirrhotic and your liver fails and then everything drops off a cliff. But up until that point, you're going to have higher activity of enzymes metabolic-wise than you would in a normal patient, non-alcoholic patient. Now for somebody who just drank a ton of alcohol one night, that almost like stuns your liver into shock for a little bit if you really went on a bender, and that can decrease temporary production of enzymes, but that should swing back. So you might see some swings with alcohol consumption. Overall, consistent moderate alcohol use is not a big deal with warfarin. All right, vitamin K. So vitamin K is a drug and obviously a vitamin. It's used to reverse warfarin, and so we can give somebody vitamin K if their warfarin gets a little bit too high. It takes about 6 hours for dietary vitamin K to start working. Depends on what you give the patient. You can do IV vitamin K, believe it or not, and it doesn't work all that much quicker though. Basically, you're just bypassing the GI tract, so instead of a 6-hour start time, it might be 4 hours to see the effect. So I always like to harp on this point because I've seen this messed up where people just haven't waited for vitamin K to work long enough and they've redosed when they should have just checked a level again. So you give somebody a dose of vitamin K, check it 12 hours later. Let's say they're in the hospital, so it's easy to do this. Check it 12 hours later. That's about 50% of the full correction from that vitamin K dose. 24 hours is about the full amount of time you need to see that whole vitamin K take effect, even if it's IV. Now, technically at 12 hours, IV should be a little further along, maybe than 50%. But I would still wait a second before you would redose. The problem with redosing vitamin K is if you really slam somebody with a lot of vitamin K, it can be really hard to get their warfarin back on track and get their INR back to where you want it. I've had patients where I've seen them give really high doses to where it's taken weeks to get them back, and then they're on injectables for that whole time period. It can be just not a convenient process for anyone. So just be mindful of vitamin K. It's not a fast process. Whether you do IV or PO depends on your personal preference. Vitamin K absorbs well from the GI tract orally. If somebody's bleeding actively, has GI issues, if they're going to go to surgical procedure soon and those couple hours matter, that might be a way to consider differentiating it there. We don't give it IM. It's painful, so don't order it that way. It burns when you give it that way. IV, it's a little bit better. Dose anywhere from 1.25 to 10 milligrams is common. Again, watch out for that 10 milligram dose. That's a whopper. If you're ever going to give somebody 10 milligrams of vitamin K, make sure you think about it a second time. Not to say it's wrong, because there are instances like somebody who is bleeding into their brain and goes, is getting other interventions at the same time. 10 milligrams of vitamin K is usually what we do. But for the person who comes in whose INR is 9, 10 milligrams is probably still way too much, just even for that person. So usually keep it conservative. I think anywhere from 1.25 to 5 milligrams, those doses are pretty common for just general reversal. Now, if somebody's emergently bleeding, that's a little bit different. So you see a lot of people come in. I see a lot of people come into our ER who just elevated INR, nothing else going on. Maybe they have a little blood in their stool or something, some real minor bleeding, but nothing significant. So that's pretty common to see. So just know how to use that strategy. If you're managing somebody on the outpatient and they come in and you check their INR, it's like 3.6 in clinic, definitely not a reason to hold a dose, definitely not a reason to send them into the hospital unless they're bleeding. But it would be a reason maybe to have them maybe eat a salad when they get home, to have anything with high vitamin K content at home. It could be a reason to have them dose reduced for a couple of days. That's an easy way to do that too. Try and use the most minimally the approach with the smallest impact to the patient. And by that I mean small doses of vitamin K, small adjustments to their warfarin. If they're on a big dose of warfarin and you hold an entire day's worth of dose, that's going to catch up with them and they're going to bounce around. Try dose reducing a couple days in a row and then bringing them back up or bringing them back in for a check. That's usually the way to do it. So again, small adjustments and subtle adjustments are usually more beneficial as long as you don't have something urgent going on, of course. Then you're going to change your goal, but that's the basics of vitamin K there. All right, direct thrombin inhibitors. I'm not going to talk about these a ton. Basically, these are used if somebody has a hit risk, so if they have that heparin-induced thrombocytopenia history, and we need to give them something IV that's fast-acting and titratable. Argatroban's a really common one for this, and it's really the only use for argatrobans. If you see somebody aren't on argatroban, that's probably why. Bivalirudin is a similar thing. Bivalirudin has some additional flexibility. It's got some indications for STEMI patients and PCI. There was a study that showed those patients had less bleeding than people on heparin, but I don't know if it's really used all that much for that reason, but it is an option. So those two would basically be for heparin alternatives. Think about them that way. Oral direct thrombin inhibitor, dabigatran or dabigatran or however you want to say it. Pradaxa is the brand name. This is the only oral direct thrombin inhibitor on the market. It was the first oral anticoagulant to really challenge warfarin to get onto the U.S. market. So it was a big deal when it first came out. Kind of lost some favor now. But it's only approved for use in AFib. It's billed as requiring no monitoring, just like the other factor Xa inhibitors we're going to talk about here. There's no CYP interactions. So one big thing that when this came out, no drug interactions, no food interactions. Well, it turns out there are actually some drug interactions because some drugs interfere with P-glycoprotein transporters, which are in the GI tract, and drugs can kind of go in and out of the GI tract and get recycled that way, and it does interact with those, so that's a little bit of a misconception. Dabigatran was not reversible. Technically it is now. I'll talk about that now, although it's really still not well understood how to use its reversal agent. So I'll talk about the controversy. So that's actually a wrong slide. You can delete that and say it is reversible now, and I've got that reversal agent in a few slides here. Half-life, 12 to 14 hours, dosed twice daily, renally eliminated, and we adjust that accordingly. Contraindicated in use of patients with mechanical valves. So all the current oral anticoagulants, with the exception of warfarin, are contraindicated for mechanical valve. So mechanical valves and what's the other thing we like to use warfarin in? What patient population? Do you remember? Renal, yes. So renal insufficiency, mechanical valves, warfarin is still king. These other drugs are taking over pretty much everywhere else, though. With dabigatran as an exception, because it's really not that common. At least not in Minnesota, not in the practices I work with. Anyway, may cause GI upset. People build this as very safe, and when the data came out with this drug first, it was like, oh, the bleeding risk looks the same as warfarin. And like anytime you anticoagulate somebody, they're going to bleed. That's going to be a risk. It's just part of the risk you have to accept to get the benefit of stroke reduction and decreased risk of thromboembolism and things like that, right? So, but we've seen a little bit more post-marketing bleeding risk than I think the company originally sold the drug as. So there's been some controversy over Pradaxa and how much bleeding it actually causes. Okay, let's talk about the factor Xa inhibitors really quick. Fondaparinux is a sub-Q injection. It's been around the longest for the factor Xas. Very similar to low molecular weight heparin. This is a drug that you would use for bridging if somebody had hit risk, and that's really all we use it for anymore. There was a period of time when it was less expensive than low molecular weight heparins like Lovenox and Aspirin, and we used it as our primary agent for that, and you certainly could. So you might go to a health system where Fondaparinux is the preferred agent for bridging because they get it at a contracted price and it's cheaper or something. Certainly fine. It also is once daily, so it's a little bit more convenient than enoxaparin, but it's more expensive too, so we don't usually use it anymore. But unless they had hit, that's really the one thing that I see it used for. So rivaroxaban, Xarelto. Xarelto is one of the big juggernauts that just came out, well, a couple years ago. It's got the most FDA-approved indications. Started with post-hip knee replacement in Europe, and then finally got approved in the U.S., and marketing AFib, VTE treatment. It was the first one to get both of those. Now, actually, I think they all have pretty much the same indication, so that's probably not a big deal anymore. Post-marketing bleed risk hasn't seemed as bad as with Pradaxa, and I say maybe we will see an increased role. I really got to update some other parts of these slides, but yes, this is a huge drug now. This is ubiquitous in medicine. It's super common, so it didn't take long at all to see this really fly off the shelves. Major CYP3A4 substrate, so it's significantly impacted by drug interactions and does require renal dosing. I'll talk about these with a lot of comparisons in more detail than you want to know in a few slides, so just hold your horses if you have questions for now. Apixaban is the other really big one. Eliquis, approved and shows good evidence in AFib. It's least renally eliminated agent. You can also use this for VTE now too. It's approved in that as well. Actually studied in a subset of patients with renal failure. So believe it or not, they did do some CKD subset dosing studies. And so they do have a little bit of an interesting way that they dose it, which I'll talk about in a few slides here. But still not recommended for dialysis patients or end-stage renal failure. The other drug on the market right now is Edoxaban or Savesa, which I don't have much to say about. It's not as popular as the other two. I don't know if it has a real advantage over the other two that I understand well. There might be some other ones we see trickle onto the market too, but certainly Eliquis and Xarelto have the lion's share of the market right now. And we actually just got a factor Xa agent antidote approved, so I'll show you that here in a few slides. Okay, let's talk about these new drugs as a whole, because this is a super popular area of medicine right now, and I think it's important to understand the concept of them and what's different about warfarin and whatnot. So target-specific oral anticoagulants, there's a couple different ways these are referred to, either TSOAX, DOAX, which is direct oral anticoagulant, or NOAC, which is a new oral anticoagulant. They're all the same thing. I think DOAC is the most popular term I've heard most recently. They aren't better than warfarin. Let's get that right out of the way. So they don't have to be better than warfarin. Warfarin's a gold standard medication that is widely recognized as reducing stroke risk in AFib patients. So when they study their drug to reduce stroke risk in AFib patients, they have to prove that they're non-inferior. That's it. They don't have to be superior to warfarin, and they won't ever have to be. That's fine. But just know that they aren't better than warfarin from an efficacy point of view, at least not right now. Different studies have different rates of warfarin control. So one thing to point out is some of the original studies looked at things like INR goal in 60% of the time. So they compared their group of people on Xarelto to a group of people whose INR was only goal rate 60% of the time. A good INR clinic should be 90% of the time. So it's a little bit not quite what I would consider standard of care. At least if I was sending a loved one to an INR clinic and they were 60% of the time, I would send them somewhere else personally. That seems really bad to me. But some patients are hard to manage, so I get that. Anyway, other good things. Bill does no dietary restrictions. There's no vitamin K interaction here, so that doesn't matter. Ideal patient. Non-elderly person with good kidney function, relatively normal weight, and poor access to lab facilities, potentially, plus or minus there. So somebody who can't get in to get their INR checked monthly or has a difficult time doing that, travels a lot, and they're otherwise healthy and compliant and everything like that, this is a great option for them, and that was one of the biggest drawbacks to warfarin. Now, the ideal patient is basically anyone that qualifies for them at this point. They're getting so much more popular. Predictable kinetics. So we don't have to monitor for these because ideally when you take it, it does the same thing in basically every person. Maybe some subtle differences. They're heavily based on renal function too. So if renal impairment's a problem, it'd be a problem with these patients. But for the most part, we're good there. Anyway, the monitoring thing might be considered a pro. Some people consider it a con that we aren't monitoring for these drugs. We really don't know how significantly it's acting on that person when they're taking it. And cost comparison. More expensive than warfarin. Warfarin's generic and cheap for the most part from a tablet point of view. And even if we factor in all the time going to monitoring and going to clinic, it's still likely more expensive to give these meds than warfarin. But insurances are paying for them now, so it's usually not a problem to get them covered. All right, I stole these slides from a colleague. And I'm not going to test you on much of this, so I'm just going to blow through it really quick. Most of it's for your reference if you want to know the differences and how they're dosed and everything like that, and the different indications as well. Stuff like that's there. Rivaroxaban is once daily dosed, with the exception of the DVT-PE loading dose period for 3 weeks. It's interesting because I think I've got some kinetics on the next slide here. Rivaroxaban's half-life isn't really any different than the other drugs. So why did they do once daily? Well, because they decided to for the clinical trials, and it worked out for them. So they got good clinical outcomes with that once daily dose, and apparently that one dose has enough continued anticoagulation effect throughout the day to make it clinically significant. So they gambled on that maybe, or maybe they saw that in animal models, an educated gamble if you want to put it that way. But anyway, it's nice that it's a once daily med, so it is a little bit more convenient. Edoxaban's also once daily, but again, the half-lives of them are basically all the same. I think I talked about all this other stuff already. Let's see if there's anything else to talk about here. With or without food, I don't care that you know that for this exam, of course. Pregnancy category. Currently for pregnancy category, heparin and low molecular weight heparin products are the only really approved things for pregnancy, and issues with DVTs and things like that, which are highly common complications during pregnancy. Apixaban got a category B rating, so it actually did some pregnancy studies in animal models. But I don't think it's really being used. However, in the future, if we see more data, that one might be an option for pregnant patients to not have to inject themselves. So we'll see where that goes. I assume that's a market that somebody will tap at some point in the future. And I'm sure one of these will be okay in pregnancy. It's just a matter of seeing which one gets the approval and studied first. I'll talk about the reversal agents here shortly. Yes? Heparin is not on here. No, these are all oral agents.
So would that be A then?
Yeah, I don't know if heparin's technically A, but it's well known. It doesn't cross the placenta. Category A is complicated. It means there's a lot of studies in pregnant patients, and it was proven to not be teratogenic. There's almost no drugs that are category A, but it's anecdotally widely used. Yeah. Outcomes. I'm not going to go through this in all these details, but you can see the comparisons, different trials versus warfarin, some of the different bleeding risks. Ischemic stroke decreases, that's what we want to see. You can even see that some of them actually showed superiority potentially to warfarin. So some of the trials did show that maybe in certain categories, better safety profiles and better efficacy, but a lot of them weren't statistically significant or powered correctly to have the statistical significance to support that, but they did come out that way, just if you look at the raw data. DVT-PE treatment. Again, some of the same things here, looking at major bleeding events, mostly lower when we're comparing it to other ones versus like an Aspirin or VK being the vitamin K antagonist, warfarin. Renal considerations. So if you want to keep this all in mind, creatinine clearance and where you can give the different drugs. This is a nice reference to have if you're out on rotations or whatever and want to peek at it and say, I can't remember and don't want to look all of them up to figure out what they are. This shows you the dose reduction for each one. And again, once you get that 15 creatinine clearance, they're all basically contraindicated. So that end stage CKD is where you get the problems with these meds. Okay. Somebody did a lot of art on this. Hepatic considerations, don't care a ton. If you have really bad liver disease, you want to look into that. Usually you're going to avoid it. You have to avoid a lot of meds with that. So for the average patient, unless they have cirrhosis, we're fine. Age considerations. The only thing I really want to talk about this, none of these have age disclaimers with the exception of Apixaban. Apixaban did some interesting studies to look at age, weight, and serum creatinine. So Apixaban actually doesn't have a dose reduction based on creatinine clearance. So this last slide was a little bit misleading in there. But what they do say is to dose reduce if you meet certain criteria. So if you're under a certain age, I think they ended up going with like 80. I'm not even going to say because I can't remember. Anyway, they said if you're under a certain age, if you're under a certain weight, and if your creatinine's over a certain amount, then you were dose reducing. You have to meet 2 of those 3 criteria. So if you're an elderly, small patient, you're going to dose reduce on Apixaban, even if your kidneys are great. So just a weird thing about apixaban, if you're ever dosing it, it's not dosed like other renally adjusted meds. It's a little bit unique in that capacity. And here's the weight considerations again. Don't care. I'll skip through the rest of these drug interactions, just there for your reference. So at the end of the day, this is really what I want you to know as far as pros and cons. So your advantages, you don't have to do an INR checks. You don't have diet restrictions, less severe bleeding for the most part, looking at the pool of evidence for most of the drugs, especially with the factor 10As. Fewer drug interactions, easier pre-op management, and no bridging with heparin or enoxaparin required with these agents. So prior to surgery, these meds have 12, 14-hour half-life. Stop it the day before, then you're good the next morning for surgery. You don't have to bridge or anything. Disadvantages, costs. They are going to be more expensive in the short term. Eventually, one will go generic. Costs will equilibrate a little bit, but for now, they are more expensive. They aren't approved for our mechanical valves or our dialysis patients. Compliance. Compliance is interesting because you actually want the patient on this to be really compliant. Because the nice thing about warfarin is if you have somebody who misses a dose here and there, if you miss a dose of warfarin, your INR is going to buffer a little bit. You aren't going to be totally out of anticoagulation. You miss one dose of one of these meds, you're gone for an entire day. You could have a risk of an embolic event at that point because these are reversible medications. They only last a day and a half or so at most, and then you're looking at being non-covered from your anticoagulant. So you do have to be really compliant with these meds or risk a clotting episode. And if you accidentally overdose on them, it can be severe as well, especially since we didn't have any reversal agents until recently, and we still don't really know exactly how to use those reversal agents. So reversal for dabigatran is idaruzumab. I don't even know how to say that. Praxbind is the brand name. It's a lot easier to remember. Praxbind or idaruzumab, I think is how you say that, binds free and thrombin-bound dabigatran and it neutralizes activity. And animal models showed reversal within 1 minute of injection, so really fast. They did this really tiny study, gave 5 grams times infusions to 90 patients or so. Only one of those patients had a thrombotic event. That's the big risk, right, when reversing anticoagulation. Are they going to throw a clot? Only one patient did out of the 90. And it is on the market now, so I should have updated that. That's been approved. It got approved 2 years ago. It's really, really expensive, like $50,000 for a dose or something insane. It is not well understood actually how to use it either because the FDA for some reason allowed this to market with very little evidence because they were like, we need to get this drug out there because people are dying from bleeds and we don't have anything really good to reverse this. We have to do something. But interestingly enough, the factor 10A counterpart, adenexant alpha, that one they made them go back and do all these extra trials for. So I don't get it what the process was, but it's probably a good thing in the long run. And I didn't put the updated studies on here, but these drugs, we thought this drug was going to come out years ago. Like 2016 or at least 2017, it kept getting delayed, and finally they got enough evidence to make the FDA happy or whatever. But this drug works very similarly too. It binds with higher affinity than they would to the endogenous factor substrate, and it can be used in multiple different factor 10A inhibitors. So you dose it a little differently. It was studied in the Anexa A, which is apixaban, and R, which is rivaroxaban trial. So they use the same drug in 2 different ones. So it's got a nice utility there where it can work in both capacities, and different dosing for the different trials was done though. And again, pretty good onset, really fast onset. When you have somebody bleeding into your brain, fast onset is really good. So that's advantage to this product. Again, this just hit the market. I don't even know if we carry it yet. It might still be, once something goes to the market, it usually takes a few months for it to get ramped up in production and actually hit the shelves. So if you ever like, oh, I just read that this drug's hitting market, give your pharmacy some time before you try and order it, or at least call and ask. What did we do before these? And so since I'm talking about these new agents that we don't fully understand the use and are really expensive, and one of the other big question marks is what do you do after you give this? So you reverse this patient's drug, and now they're sitting in your ICU. Do you check a level on them? Do you redose them? Do you start them on heparin? Like what exactly are you supposed to do? We don't really have any guidelines to document that next step, and that's a big question mark for what we do with these meds. What we did before this, fresh frozen plasma, if you give somebody a bunch of FFP, it can decrease INR. Usually can't get it much further below 1.8 though, so you're still going to get some bleeding. And fresh frozen plasma is volume intensive. To get somebody from like an INR of 10 to 1.8 would require massive amounts of FFP. It's not practical. For a little bit of decrease, it's fine. FFP basically just has clotting factors in it, so when you infuse it, they get the natural clotting factors back into circulation. PCC is prothrombin complex concentrate. Kcentra is the brand name of this, and it contains active clotting factors, and it's used for warfarin reversal for a long time. It's the gold standard for warfarin reversal. Works very quickly. It's very effective. What we started doing is using it for the factor 10As because, again, somebody comes in with a severe bleed, they're dying, there's nothing else to do, so I'm going to give them this because I have nothing else. So they started doing some trials on this and showed that it is relatively effective for reversing some of the newer options, and it still is our option for reversing. So we still, Praxbind, I don't know if we'd use that for dabigatran. I've never actually had that come up. But if somebody came in with a factor 10A reversal situation, we would use this drug over adonexant alpha, at least at this time, until we get that drug, until we know how to use it. PCC is also super expensive. It's like $25K for a dose or something, for a max dose. Dosing's weight-based, INR-based, and dosing is all in terms of warfarin. So when you're using it for a factor 10A inhibitor, you're kind of going outside the approved indications of the medication. All right. Okay, almost done. Thrombolytics. So thrombolytics are what we talked about last week during the acute coronary syndrome lecture. I just want to mention them briefly because these are going to break clots. So switching gears, just to review this quickly. Really clinically significant for stroke and then MI that can't get to cath labs. So that's all I want you to know about thrombolytics for now. We'll talk about thrombolytics in a lot more detail during stroke. I'll talk about all the contraindications and all that stuff, and I want you to know a little bit more about it. For now, if you see anything that ends in place come up on an exam, it's probably not the correct answer because I'm not going to ask you about treating somebody with a thrombolytic. So, okay. I want to talk about VTE review because there isn't really a module for this in my lecture, and I want to make sure we're all kind of on the same page. So just to talk through a patient who might have a venous thromboembolism and what it might look like. So usual presentation is clinic or ED. You get somebody with either a pulmonary embolism or a DVT. So let's use pulmonary embolism. So they're shortness of breath. They're in your ED. You guys are going to learn about the diagnostic stuff for this. You guys talk about this in another class at some point, thank God. So you do D-dimer or something like that. You can do imaging to figure this stuff out. Again, not my cup of tea, but that's the general diagnostic pathway you go. Anyway, you diagnose PE. What do you do? Anybody just want to shout something out? So I heard a couple different things. Check their INR. I hear heparin. I hear thrombolytics.
Big PE.
Yes. Okay. How big is your PE? What's your symptoms? Are you dying? Are you going to cardiac arrest from your PE? There's a big no, right? No for the patient. It's a bad thing. So, okay. So here's what you usually could do. You can do thrombolytics if the patient's in an arrest, which PEs can cause pulseless electrical activity, so they can be fatal if they're really big. You can give a push of alteplase and hope to God that it, literally I'm saying that because sometimes it's like, this is the only thing that will save your life. Praying for you at this point. So PE resolution due to that immediate action of the clot busting drug, the alteplase. Now, if you have a patient who has a pretty massive PE and is symptomatic and somewhat unstable, but they aren't dying, that's where you can do a slower infusion of TPA over a couple hours, and that's indicated as well. Where it gets a little trickier is what you do afterwards. So yes, you could start somebody on heparin after that while you get their warfarin up to par. So eventually you need that person to be anticoagulated, right? So that's the next step. So immediate steps could involve lytics for emergent. What if you have somebody who's doing okay and they just maybe a little bit of a cough and don't feel great, but maybe desatting slightly, but otherwise they're okay? Do you need to do TPA? Could you just start them on an anticoagulant? Yeah. So that's the question. What anticoagulant do you need to start? When I started practicing in the emergency department, again, in relative term of history, not very long ago, right? I've been there 7 years or so. We never would have discharged somebody home with a PE. Now we do it pretty routinely. So you can actually discharge somebody on a oral anticoagulant if they're doing okay, if they're relatively stable. just like you would a DVT. DVT, really common to discharge somebody. Rarely an emergency that's going to happen from a DVT. And usually you're going to be on an anticoagulant for 3, 6, maybe a little bit more months, depending on if you've had episodes in the past or how high risk you are. But that's pretty common for a first encounter. So the question is what anticoagulant you would use. And so if somebody's going inpatient, use IP, you're just going to start them on a heparin drip. I would say if higher risk, maybe. I don't know. You could admit somebody to overnight and start them on an oral anticoagulant. There's nothing really wrong with that strategy. The end game to think about is what do you get them out of the hospital on? How fast can you get them out of the hospital? Because these things should be able to manage fairly quickly. And again, if they're unstable, you can discharge these patients fairly quickly. So the really nice thing about the new oral anticoagulants is gone are the days of sitting in the hospital for a week because your heparin drip's going and your INR is not getting to where you need it to be. We don't have to worry about that anymore for a lot of patients. So that's where these rivaroxaban and apixaban come in handy. So almost all the time I'll see that used as the option currently that's popular for our ED docs and our ED provider group is they'll prescribe somebody one of the new agents and send them home, or they'll admit them on heparin if they're unstable, and eventually that person will get converted to a new oral. The nice thing about those new orals, you stop the heparin, start the oral right away, you can discharge them that same day. No real reason to keep them, no monitoring involved, right? So very different school of thought from the warfarin where you really had to meticulously monitor and get it up to therapeutic value. You could still do the warfarin route. You could still send somebody home in a PE situation on Lovenox and warfarin. You just have to make sure their follow-up's established. And you have to give them enough to get them through like a week or so. Does that make sense? Any questions about? Oh, that's a good question. If it's a DVT, probably not. You might get an OB consult, just double check, but I don't think you would need to. PE probably.
Can you send someone home with Lovenox, like shock?
Yep.
Just like...
Yep. Before these drugs existed, I did a lot of education on that, and now it's like totally changed. We don't do it very often at all. I'd probably get a couple a night when I'd work in the ER where they say, I'm starting this guy on Lovenox Coumadin, can you go talk to him about it? And that was kind of a thing pharmacists did. We did the shot education, we talked about warfarin and all that stuff, but rarely happens. If it happens now, I get kind of surprised. Now it's like, can you call the outpatient pharmacy and see if their insurance pays for Xarelto or apixaban? I'm like, okay, yes, I'll be your... No, it's okay. I don't mind doing that. That's a great thing, by the way, to think about, too, just as a side note, is insurances don't always pay for both of those, too. So, again, Xarelto and Eliquis are the two common ones. They're both fine to prescribe. I don't think there's a huge advantage one over the other. And a lot of times insurance will dictate which one the patient can have based on coverage. So give your pharmacy a call. They can run test claims on patients and see what's covered. A lot of times pharmacies will have coupon codes too to get patients through like even a year's supply. They might be able to get for like a $10 a month copay or free almost. Just depends. So there's a lot of incentives out there from the drug companies to get people on their medications, and a lot of pharmacies have access to that type of stuff. Okay, that took me longer than I anticipated, but do you guys have any exam-related questions or any other content-related questions? Yes.
So,
Go ahead.
for study, you're starting a patient on heparin before they go to the cath.
Correct.
How is that not like a risk for bleeding?
Good question. I think it's such a low bleed risk procedure in general that you don't have a high risk of bleeding, having a huge amount of blood coming out during a catheterization procedure. I mean, I know you're going in an artery, but I believe they must be able to do it where it's a minimally invasive process that doesn't have a huge risk of bleeding. Yeah, it's a good question.
Usually you take them off of it and you take like
Right. No, yeah, you bolus them with a big thing of heparin, and it works pretty much quickly. So by the time they're in the cath lab, they're hopefully, yeah, I think that's the only answer I can give. I wouldn't know for sure. You'd have to ask an interventional cardiologist.
Yeah.
Yes.
So I have two questions. Sort of, last week in one of the lectures you posted, you mentioned like a forum posting assignment.
Oh yeah.
Is that going to be like?
I was going to put that up this week and I forgot. Yes, you have until the end of the semester to get it done, and I'll put it up tonight or tomorrow.
Okay. And my other question is, kind of really broad, but as we're studying, like, for the exam, what areas would you suggest, like, focusing on, and, like, are there any areas that you, like, don't really care about going into the exam?
If I said I don't care about it, I don't care about it. I don't know. I think it's all fairly relevant as far as like clinical testability goes. So for clinical cases, I mean, focus on hypertension, focus on heart failure, acute diastolic heart failure. I'm not going to get into a lot of the nitty gritty for acute diastolic, but definitely understand dilators versus inotropes and that type of stuff. You should be okay. And I'm going to give you strong symptoms and that stuff. So from a point of getting really tweaking medication regimens, I'd like you to know blood pressure really well. So if I give you a patient on a blood pressure regimen, be able to analyze it. If I give you side effects and how to optimize that, that's where you might need to get into a little bit more detail. Whereas like with an acute diastolic heart failure patient, I might just want you to know, okay, this is a patient that needs an inotrope right now. That's really all I care about. I don't care if you know how to dose an inotrope or any of that stuff. I just want you to know when that's applicable based on the symptoms I'll give you. So I give you a patient who's congested and has bad cardiac output. I'll make it obvious in the symptoms. That's, inotrope should be right on the top of your mind. So stuff like that. The more acute stuff, I just want you to know broadly. Acute coronary syndrome, I'd like you to know kind of the intro stuff we give, aspirin, pain relief, how we relieve pain, so nitroglycerin, things like that. And post-care, like when do you start medications? What should a post-ACS patient be on? That type of stuff. Yeah. Arrhythmia, remember there's really only like 4 drugs that matter. So amiodarone, dofetilide, sotalol, and then flecainide/propafenone, which are essentially interchangeable. So if you know those and you know those little nuances, you'll be okay. Obviously, I probably will get a heart failure patient with an arrhythmia, and you'll have to pick a drug. So know those ones. Yeah.
Are the rest of our classes online?
I think I have one more in face-to-face. It might be different on the syllabus. I'll double check that because I think I made a change based on Wally wanting to come in and observe one. He had to come in and observe one. But yeah, if he only has 1 choice left, I don't know if he's going to do that. Anyway, I'll double check that. Okay. Yeah.
Sorry. Do you have any extra review questions on hand? Because I know you have the last one we had review questions.
Okay.
So maybe some of the hypertensive stuff.
Sure.
It's nice to practice.
Sure. I'll see what I can. I will post a case too, like I did with the last couple.
Yeah.
But yeah, I'll see what I can find. Okay.